So now I'm going to show the proper use of an OPA or oropharyngeal airway. This is indicated when the patient has a GCS of 8 or lower or scoring a 2 or less in their verbal response. Before we do anything, we want to check that his mouth is open and the airway is clear of any obstructions. Next, we want to measure the OPA. So you do this from the first incisors to the angle of the mandible or the edge of the mouth to the edge of the ear. From the first incisors to the angle of the mandible. So this patient is a 3. So for inserting this, we want to have the curvature facing the roof of the mouth, and as we push it in, we want to rotate 180 degrees, and it will just slot right in there. So we want to avoid catching the tongue, and then we assess if the patient accepts the OPA. We can tell this by if the OPA starts inducing vomiting or damages and obstructs the airway. So now I'm going to show the proper use and application of an NPA, nasal pharyngeal airway. First of all, you do this by measuring the patient and what size they require. So you go from the largest nostril to the angle of the mandible. So this one here is too long. You go with this one here. That looks perfect. So what you want to do is you want to lubricate it to allow easy access into the nose. You start off by positioning it 90 degrees away from the patient's face, and as you push it in, just slowly rotate. If there's resistance, you can rotate at 180 degrees, or if there's still further resistance, you can switch nostrils. You insert the NPA until the flange reaches the nostril. A contraindication to this would be if the patient has a suspected skull fracture, but the benefits are is if the patients have a higher GCS, you can apply this instead of an OPA. So when attending to a patient, especially a patient that has a potential cardiac arrest, we want to use our doctor's ABCs mnemonic, which so we first off want to just evaluate any dangers around, identify them, and potentially stop them from happening. Next, we want a response out of the patient. So, excuse me, sir, can you hear me? Can you hear me, sir? So, what I want to do is I want to rub on the sternum or head on the clavicle to form some form of discomfort. So he's clearly unresponsive. Next, I would want to call for backup. So AUT1 calling comms. Patient is R49, requesting R50 backup. Next, we want to check his airway. So I want to see if that's all clear. We will insert an OPA. So I have that ready. Next, I want to just listen for any signs of breathing or feel for chest rise for 10 seconds. So still no signs of breathing and no chest rise, so we'll have to potentially start CPR. So Dave, can I get you to remove any of the restricted clothing and start compressions? Doing 30 sets of 30 compressions. So I've inserted the OPA. Next I want to get the defib ready. Placing these strips on where it's indicated.
Analyzing heart rhythm. Do not touch the patient. Shock advised.
So let the AED charge.
Stay clear of patient. Deliver shock now. Red shock
So
delivered.
Stay clear.
Paused. Start CPR.
So Dave, can I get you to continue doing that? 30 compressions. While this is happening, we want to attempt to gather some sort of patient history, or try family members or
25,
bystanders.
26, 27, 28, 29, 30.
So a C grip, and just ventilate twice. 1, 2. Checking for chest rise, and making sure that seal here is adequate. If not, we can always troubleshoot if needed. So compression should not be
25,
interrupted
26,
for
27,
more than
28, 29,
5
30.
seconds. So we are seeing some chest rise. In addition to this, we can use the suction tool to scoop out any build-up of saliva or any obstructed gastric juices that may flow out of the
25,
as well.
26, 27, 28, 29, 30.
Stop CPR. Analyzing heart rhythm.
So now I'm going to switch positions.
Stay clear of patient. Shock advised.
So it's going to charge.
Deliver shock now. Press the orange button. Shock delivered. Paused. Start CPR.
So next I want to start CPR. I want to ensure that it's the correct rate, depth and hand position, and also there is some form of recoil. So I want to go down to about the bottom of the ribs and put my hand on top of the sternum and just going to start compressions. I need to do about 100 compressions per minute. Yeah. We're getting adequate recoil. We should do compressions for no longer than 2-minute sets because we do fatigue. 25, 26, 27, 28, 29, 30. Yeah. So now I'm going to demonstrate proper use of suction. First of all, you need to check that your machine is working. So you do this by turning it on and obstructing the tubing, making sure that the meter rises. So that's all working perfectly. When using suction, you want to put the patient in the lateral position on the side, supporting the head. Next, you want to turn on the suction and close circuit suction in his mouth, just as far as you can see. Small circular motions, only sucking on the way out for no longer than 10 seconds. So complications of this could include inducing or vomiting or bradycardia, and also hypoxia, aspiration, soft tissue trauma. One other aspect of this is you should not use a rigid catheter such as this on a moving vehicle, but that you would use a soft catheter, something like this. So now I'm going to demonstrate oxygen delivery. First of all, you need to get an oxygen regulator, and you need to check that the Bodoc seal is unregulated and it's all nice and smooth. You can identify these as an oxygen regulator because they have the 2 pins. So first of all, you want to get your oxygen tank, place the regulator on, putting in the pins, tightening up, and then doing a quarter turn. Next, you want to check the amount of oxygen in the tank. So you want to turn this on. So this one is half full. Next, you want to attach the tubing, oxygen tubing, onto the tank and onto a mask, and turn it on just to check the flow rates. So that's all working. Oxygen delivery is indicated for patients when they have a SpO2 of less than 94%, or they have an obstructed airway, respiratory distress, carbon monoxide poisoning, or even smoke inhalation. Depending on the severity of oxygen deprivation, multiple delivery systems can be utilized, such as nasal prongs, which deliver 28% oxygen at about 2 to 4 litres per minute. Next you have your acute mask, or Hudson mask, which delivers 60% of oxygen at 6 to 8 litres per minute. Then you have your non-rebreather mask, which delivers 90% of oxygen with the tank at 10 litres per minute. And then you have your bag valve mask and reservoir, which delivers 98% of oxygen when the tank is turned on to 10 to 15 litres per minute. And lastly, you also have your nebulizer, which delivers 60% of oxygen at 6 to 8 litres per minute. So when a patient is experiencing oxygen deprivation and they have a lower SpO2 level, we can use an acute mask, which delivers again 60% oxygen when you turn on to 6 to 8 litres per minute. So Dave, I see you're experiencing shortness of breath, just a little bit. What we're going to do is I'm just going to place this mask over your face and we're just going to give you some oxygen. Is that alright?
Yes, thank you very much.
So I'm just going to place this over your head. not on the ears. That's fine. Next we're going to turn on the oxygen. And I'm going to turn this to 6 or 8 litres per minute, just to deliver the oxygen. So it's on 6 litres. So ensuring it has a nice tight seal, we can tighten the seal by bending it over the nose. But apart from that, Dave, are you receiving oxygen?
Yes.
Next I had to flush the O2. So I'm just going to take this off you here. So we'll turn off the oxygen and take off this valve. Take off this tubing, sorry. And next just turn it on, flush out any remaining oxygen in the regulator. And there we have it. Next I'll be showing the proper use of a bag valve mask and reservoir. So what you want to do first is check that both sides have no leaks. So you take this off. So that's alright, it has no leaks in there. And again, yeah, that's going well, so that's fine. So next you want to attach the bag valve mask to oxygen. And we're going to set this to 10 litres per minute, making sure that the reservoir fills adequately. Next we want to insert an OPA into the patient. From the head of the patient we want to place the bag mask over the top using a C-grip and ventilate the patient every 5 to 8 seconds. So we're going to have to assess that there's adequate chest rise and there's no gastric inflation. For preventing gastric inflation, a second person can come along and apply cricoid pressure if necessary. The purpose of this is to occlude the esophagus to prevent gastric aspiration during the intubation or resuscitation. Secondly, you want to assess the effectiveness of the bag valve mask using a MONES acronym, which is the mask seal, making sure it seals properly. I'm going to do a defib orientation. So this here is the Philips MRX. So first of all you want to turn on the monitor. So this is it here turning on. That's it on. Just got to check the batteries. So to do this, you turn around and we have 2 battery packs right here. You pull them out and then you press the button on top and you can see that this is a full battery. Next we want to place the defibrillator in manual mode, so we just turn it on. And next we want to do an operational check. And run op check, so we just do that. That's it there, doing an operational check on itself. Once the operational check is complete, we can now do a defibrillation test. So next we want to get our defib cord and attach a test load to it. Just by plugging that into this cord here. Next we want to set the charge at 50 joules. Next we want to click charge. So that's charged. And to fire off the charge, or to shock, we press the shock button. And then the shock is administered. If we wanted to disarm a charge, it's a similar process. We charge it up, and we just press the soft button down here that says disarm. And then the defib is disarmed. So if we're on manual mode, we can switch to AED mode by turning the dial to
Apply
AED.
pads to patient's bare chest.
So that will turn it into AED mode, and that will analyze and suggest whether a shock is necessary. So next we can apply a 3-lead ECG onto a patient, so I'm just going to use myself. So we've got 3 colours, red, white and black. The white piece, the white lead, goes on below the second rib on the right hand side. So there. Next is the black one, black lead, which goes on the left hand side under the second rib. Thirdly, you have your red lead, which goes right at the bottom of the left hand side, at the bottom of the rib cage. So as you can see, it's detecting the electroactivity of my heart, and we can change between the the leads by pressing this button here. We can adjust the QRS volume by going in through the menu, going down to volume, QRS, and we can change the different volumes. We can adjust the amplitude of the ECG by selecting the displayed waves. Wave 1. And we can adjust the amplitude by just selecting the size that we want. It's times 4, times 2, times 1, half, or a quarter. Next we have the non-invasive blood pressure button, which is down the bottom here. So you attach your blood pressure cuff to the life pack through the side. Place it on the arm. Once the non-invasive blood pressure cuff is on, you press the start in MBP, and that will just begin to inflate. In addition to this, we also have an SpO2 detector, which is the same as the blood pressure cuff. Gets pushed into the side here. And that can detect your SpO2 right over here. Lastly, if we wanted to change the ECG paper, we would turn it off and pull this latch back so this pops out, and then we have our ECG paper. This was quite full. We do have a spare in the back, so we want to place this one back in. Make sure it's sitting in nicely. Pull a little bit of the paper through. Make sure it's even, and then just clip it back in. So now I'm going to demonstrate proper wound and hemorrhage control. There are two types. There's catastrophic, and then there's just regular hemorrhage control. First of all, with just regular hemorrhage control, you want to expose the wound, clear any restrictive clothing. So right here we'll say Sam has a laceration to his forearm. So what we want to do is we want to clean the wound. So we take our saline, open this up, take a gauze, not out of the packet, we just want to pour some in, just lubricate the gauze, take the gauze out. We're just going to clean around Sam's wound. So that's all clean. So now we want to pack the wound if it's necessary. So we just get some more gauze, some more saline, just to keep the laceration from drying out and keeping the gauze moist so it doesn't pull on the laceration. So I'm going to fold this up. We want to cover the wound with a small as possible dressing. So we're just going to fold this up here. To apply the most pressure, we want the smallest amount of dressing. So next we grab the combine dressing. We're going to fold this up as well, as little as possible, to cover the wound, to make sure that the most possible pressure is applied. Next we're going to grab our crepe bandage, place it on top, and just wrap it around the bandage, twisting and tightening every time the bandage orbits the wound. Just twisting again. It's nice and tight, putting a lot of pressure on the wound, a lot of direct pressure. Yeah, and just wrapping this around, and finally just tuck it in on itself, just to hold it there secure. So is that nice and tight there, Sam?
Yeah, that's good, thank you.
So if it is quite catastrophic, the hemorrhage, you can also apply a tourniquet. These get applied 10 centimeters proximal to the wound. So if the wound here is on Sam's forearm, we're just going to put this tourniquet up on his bicep up here. So if I could just get your arm through here, Sam. You want these quite tight. You're going to put them on as tight as they can go. So with these, you want to crank these until the bleeding stops or till the distal pulse disappears. These are quite painful, so analgesia will need to be used. If however this one tourniquet does not work, you can always apply another one proximal to this one. Once the tourniquet has been applied, it should be uncovered and not removed. Also, you want to document the time that you apply the tourniquets. I'm going to demonstrate proper use of a C-collar. So when attending a patient that has a suspected C-spine injury, you would perform a nexus assessment. This would be to determine if there's any tenderness at the posterior midline of the C-spine, or there's evidence of intoxication. This will be done through a Pearl assessment. There also may be a decrease in the level of alertness, or a neurological deficit, which may dampen the feeling to the lower extremities. There may also be distracting, painful injuries in addition to the C-spine injury. So Bruce here is my patient, and I'll be performing a nexus assessment before applying this. A nexus assessment may not indicate that a C-spine collar is necessary. However, depending on the mechanism of injury, this may change the likelihood that a C-spine collar is actually necessary. So it's better to be safe than sorry. So Bruce, I'm just going to take you through a nexus assessment. Is that alright?
That's alright.
So first of all, I want to check if there's any posterior midline tenderness of the C-spine. So I'm just going to reach around the back of your neck and just feel any. So there's a little bit of tenderness there.
Yeah.
Quite sore. Have you been taking any alcohol? Have you been drinking tonight? Just a little bit. So now I'm just going to squeeze the ends of your fingers. Can you feel that?
Not so much.
Not so much. Can you wriggle your feet? Yep, so got some movement of the feet, a little numbness of the hands. So these are all indications that a C collar may be applied. To do this, we'll need a person to come in and stabilize Bruce's head. So it's got a firm application of the hands holding the head tightly. Next, I'm just going to measure with my hands the size of C collar that Bruce will require. So it's a three fingers. So I bring up my C collar, measure. So checking the size here, Bruce is a no neck. We're just going to bend this so it comes easily, can be applied more easily. Just bends. Now I'm going to come around the front of it. Bruce, I'm just going to put this around your neck, alright?
Yeah.
Come right round. Just Velcro strap. Now Bruce, that's a little bit uncomfortable, but it's going to stabilize the C-spine, is that alright?
Yep.
Now I'm going to demonstrate fracture management using a box split. First of all, you want to explain the procedure and gain consent from the patient. So Sam, I'm just going to take a look at your leg here, and I'm just going to probably splint it because it looks like it's broken.
Okay,
is
cool.
that alright? Thank you. So now I'm going to use the mnemonic plasters to assess the likelihood of fracture. So Sam, is there quite a bit of pain here?
Yeah, quite a
Quite a bit of pain? Out of 10, how severe is that pain?
probably like an 8 or a 9.
Is there loss of function, so can you move your ankle at all?
No.
So there's quite a bit of loss of function. There's no real unusual movement, but there is some minor swelling. And there's also a little bit of deformity in the muscle and the ankle itself. So there's also some irregularity. So Sam's pain scale indicated that he would require some form of pain relief. So when administering any drug, you want to perform a drug check. Now this could include checking the dosage, the expiry date, and the integrity of the packaging, also the clarity of the drug. Also, we have to also check if there are any known allergies to any drugs, because a known allergy to a drug is a clear contraindication to the administering of the drug. Pain reliefs that we can administer would include internups and methoxyflurane. For this scenario, we're going to use methoxyflurane. So this happens in the 3 ml ampules being poured into the plastic container. So contraindications to this form of pain relief would include known renal impairment, or family or personal history of malignant hypothermia, or if Sam could not make commands. So Sam, could I just get you to sit forward, please? Do you have any known renal impairment?
No.
No renal impairment. Have you had any methoxy in the past week?
Nope.
And so you can also make commands. And do you have any known history of malignant hypothermia?
No.
Nope. So I'm going to get you to just suck on this. Take a few deep breaths. So the onset of action of this will occur from about 2 to 5 minutes. From about 2 to 5 breaths, you'll start feeling it, and it'll last about 5 to 10 minutes, an adequate amount of time for us to apply a splint. Side effects of this could include drowsiness, lightheadedness, and nausea. So Sam, you may feel a bit nauseous or drowsy, and you'll feel a bit lightheaded. So for this suspected tibia-fibia fracture, we're going to use a box splint, as that would be deemed most appropriate. So Sam, what I'm going to do is I'm just going to attach this box splint to you. So I'm going to straighten your leg and fit it comfortably in here. I'm just going to bandage it up above and below the fracture, so it's all nice and secure.
Okay.
Right. So as I'm doing this, just make sure you're breathing on your methoxy fluorine, making sure you breathe in and out through the inhaler. So now I'm going to have an on-sider step in, so I can apply this box splint. So Sam, we're just going to lift up your leg and I'm going to slide this underneath.
Okay.
Making sure you're breathing in and out through your inhaler. Take the pen away, and we're going to have Dave lift that up. Dave, slide that here. I'll slide the next one. Yeah. So securing above and below the fracture. Nice and tight. So is that comfortable, Sam?
Yeah.
And then we have this one. The neurological and cardiovascular integrity. So again, we just check the capillary refill of both his feet, make sure it's the same as it was before, and also check the distal pulse. And Sam, can you feel me tapping on your feet?
Yep.
Yep. So it's still all intact. Proper use of a blood pressure cuff. First of all, before you do this, you need to gain the consent from the patient. So is it alright if I take your blood pressure?
Yep.
Great. So next, you want to take away any restrictive clothing from the arm that you're going to be taking the blood pressure from. Next, you want to place the blood pressure cuff on with the artery mark of where his brachial pulse will be. Is this comfortable? Yeah. Just get you to hold this. Next, you want to find the brachial pulse. We're going to inflate the cuff. And so I can no longer feel this pulse. So I want to place the stethoscope on top of the brachial pulse. I'm going to slowly release this valve until I can hear the loudest audible pulse. So that's 123 systolic. And now keep releasing it until I can no longer hear this pulse. It'll be 74 diastolic. Taking a radial pulse, you take this by palpating just below the thumb, medial to the anatomical snuff box. So if Bruce, may I take your pulse? Yep. So I'm just going to put my fingers where they need to go. There we go. Now I'm going to count for 30 seconds, counting each pulse, and then doubling it. So that was 30 seconds. That was a pulse of 40. So we're going to double that to get 80 beats per minute. So when taking pulse is the strength and regularity of it. So Bruce, your pulse was fairly strong and it was quite regular.
Thank you.
So now we're doing a respiratory assessment. This first requires an explanation and to gain consent from the patient. So Dave, I'm just going to do a respiratory assessment. Let's just check the airway is all right and clear. So first off, you want to get a respiratory rate. When a patient is conscious of this, they may change their breathing habits. So the best thing to do would be to actually disguise it under a radial pulse checking. So take the hand up, I'm just going to check your pulse. Place the arm in front of him, across his chest. You can clearly feel his chest moving as he breathes. So I'm just going to count for 10 seconds, how many breaths he does. 10 seconds. So while also measuring the respiratory rate, take notice of the rise and fall of the lungs. This is a way to assess the amount of volume of air that's been inhaled. So that's 10 seconds. That was 3 breaths, so you times that by 6 to get for a total of a minute. So that was 18 breaths, so that's well in between the recommended respiratory rate of 12 to 20 breaths per minute. So next we're going to use a stethoscope to auscultate at the mid-auxiliary line, which is at the base of the lungs, anteriorly and posteriorly. So Dave, I'm just going to reach up under your shirt with my stethoscope. Alright? Yes. And can I get you to breathe in deeply twice? Using the stethoscope, what you're actually looking out for, or listening out for, is the clarity and integrity of the lungs. making sure there's a good tidal volume coming into the lungs. So for the final aspect of a respiratory assessment is a words per breath. This is just to assess the effort of breathing. So Dave, can I get you to count to 10, please?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So that's 10 words per breath, so here is an adequate effort.